differences in quality among their health plans. And I'd submit that that's still true for most people today. And if you ask most people what's important to you in a health plan, it's not, this plan is, I chose this plan because it's clearly superior in terms of getting better outcomes for people like me at a lower cost. They say, no, I chose this plan because my doctor's in it. So we still have a long way to go on giving people confidence that they can make a choice about their coverage based on something other than what their most trusted health professional recommends. And a good sign that we have gotten there in terms of valid measures of quality to go along with the emphasis on cost is that people will be more willing to make decisions based on the information they get as opposed to just based on what their doctor may be telling them. We're there in some areas already. I mentioned Part D earlier for a reason. People believe, most people in this country believe that if a generic drug is available for their condition and it costs a lot less, it's okay to switch because it's the same drug. And most people were willing, many people, it turns out in Medicare, are willing to try a preferred brand name drug that costs much less than the one that their doctor initially prescribed because they think it can do just about as good of a job for their health. People aren't there yet when it comes to picking their surgeon or picking their primary care doctor or picking a health plan. So we've still got some more work to do on making these quality measures work. And when that happens, then you'll really have competition around quality and cost. So that's one thing, is these better measures of quality and really driving that forward. Second thing is there's this problem of adverse selection that I mentioned, that a lot of competition in the 1990s and still too much competition today is about on avoiding people with high costs, even though, if you think about the actual facts, it's those people with high costs that have the most to gain from care coordination, from all the kinds of services that a good health plan ought to be able to provide. And that's our fault from the policymaking standpoint. If we set up a system where you can make more money by competing on excluding the chronically ill than you can by providing better care for the chronically ill, and there's tremendous opportunities to do that. I gave you the statistics. There's appalling how bad care and coordination for chronic illness is in this country. There's tremendous opportunities to do much better than we're doing today. And there ought to be a way to focus competition to make that happen better. In Medicare, a big step over the last few years has been what's called risk adjustment of payment systems. So now in both Medicare Part D and in the Medicare Advantage plans, if you attract somebody into your plan who's 65 and healthy, that's great, but Medicare is going to pay you relatively less money. All the Medicare Advantage plans are getting paid well today. That's another related topic that I'm happy to talk about, but relatively less money if you attract and keep somebody who's 65 and healthy. In contrast, if you attract and keep somebody who's 85 and has 4 chronic diseases or who has HIV/AIDS, Medicare will pay you 10, 12 times more. And there now are actually some plans, some private health plans in Medicare that are called special needs plans that are sort of the reverse of the traditional criticism of HMOs. These are plans that are only open to people with chronic illnesses. Why? Because they're offering a lot of services like